Hi guys, it's Mrs. Bartels. I'm going to do the taped lecture for chapter 22, slides 1 through 14. I'm in my Schoology classroom. I went to the materials tab, and then from there I clicked on module 3. I'll do it really quick so you guys can see. The materials tab, and then I'm going to come down to module 3. Okay, and I'm going to slide down and find chapters 22 and 26. There they are. I'm going to click on it. You'll see that there's daily assignments for you, and I'm going to go right to the PowerPoints for chapter 22. So chapter 22 PowerPoints, and then I'm going to put them over here. All right, it's going to take a minute to open them up. And chapter 22 starts on page 320. We're going pages 320 to 324, slides 1 through 14. And this is a chapter about vowel movements, okay? And the vowel needs elimination, or your person passing a vowel movement or having gas, okay? So that's what this chapter is about. Or not being able to pass vowel movements and being constipated or having diarrhea. Okay. So some key terms that you need to know. If you open up your book to page 320, I have the key terms highlighted: defecation, D-E-F-A-C-A-T-I-O-N. We will talk about it in the slides as well. I also have the key term of enema, E-N-E-M-A, highlighted. Key term of fecal impaction, highlighted. Okay, so those are my key terms on page 320 that I highlighted. Then the chapter starts out talking about how vowel elimination is a basic need. It's a physical need. We have to be able to have a vowel movement. It's a normal process. It needs to happen. It's a way of our body getting rid of waste, just like our urine is waste. Okay. So let me go to the next slide for you. Key term. There we go. So normal vowel elimination. Vowel means having a vowel movement or having, I guess we could use the word poop if you guys want to. Okay, so it means the person defecating, having a vowel movement, having feces come out of them, or taking a poop. But we don't use the word poop because that's not appropriate for nursing. Okay, so vowel elimination, we're getting rid of the waste. We're eliminating it. So we're having a vowel movement. Normal vowel elimination is different for everybody. Some people have it at a certain time each day, like every morning or every bedtime. Some might only go to the bathroom and have a vowel movement once a day. Some might go twice a day. Some might actually go 2 or 3 days without having a vowel movement. That's normal for them. So it depends on the person and what their pattern is. Okay, it depends on what their vowel is used to doing. You do have to help your person with vowel elimination sometimes. So in order to do that, you need to understand what the terms are that we use. So when somebody defecates, it's called defecation. Again, anything that ends in ION is a process. So ION, okay, defecation. Feck is a vowel movement, okay, feces. So defecation is the process of excreting feces from the rectum for the anus. It's the process of having a vowel movement. It's taking a poop. It's sitting on the toilet and going number 2. But again, we don't use number 2. We don't use the word poop. Instead, we say bowel movement, or the patient defecated, okay, or they eliminated their bowels. So those are words that we use. So defecation is sitting down to have a bowel movement. It's the process of moving feces. So process is ION. Fec is feces from the rectum to the anus, okay? Feces is what we call the waste when it's inside us. So feces is the semi-solid mass of waste products in the colon. So it's inside us. And when the feces comes out of us and lands in the toilet or comes through our anus, it's called stool. Okay? So they're all called bowel movements. The process of having a bowel movement is defecation. When it's inside us, it's called feces. When it passes through our anus and comes outside, it's called stool and no longer feces. So stool is when we have it come out of us. Okay, so that's another word you'll hear. So usually we'll say the patient defecated, they passed their bowels, they had a bowel movement, or they had a stool. Those are all words meaning they went to the bathroom, number 2. Okay. And those terms can be found on page 321 of your book. Okay, observations, things that we need to watch for. I know it sounds crazy, but we do have to look at people's poop to make sure things are going the right way, that they're the right color, they're the right consistency, the right texture. Okay. So if you look on page 321 of your book, there are different pictures of poop. Okay. And it talks about what we look for. Poop is normally a light brown. It's usually a brown. Okay. However, if we have some bleeding or stomach problems going on, and you might have bleeding in the intestine or bleeding in the stomach, our poop or our bowel movements will not be brown. They might be black. They might be a dark brown and tarry, meaning they're really, when you wipe, they're like putty. They're like hard to wipe. They stick to the toilet paper. They stick to the patient. Okay, they're kind of like asphalt on a street. They're real black and tarry. Okay, bleeding in the lower colon and the rectum causes red colored stools. So if we have bleeding going on in the higher part of our stomach, in the high part of our intestines, it's going to be black and tarry because it sits in our body a while. The blood sits inside of our body a while and it's up high. It's got to work its way down. So when blood sits around for a while, it gets darker. So you'll see that black tarry stool. If we're bleeding in the lower part of our colon, which is close to our rectum, our stools will be red colored. They'll look red. They'll look like blood. Okay. So if somebody's having black or tarry stools, they might have some kind of bleeding going up high in their stomach. If they're having red stools, it may be lower in the stomach or in the rectal area that they're having bleeding. Diseases and different infections can also change the color of our stools. A normal stool is brown. It's soft, it's formed, it's moist, and it's shaped like the rectum. Okay. It's shaped like a little banana. Or I always say it could be shaped like a Snickers bar or an almond bar, an almond joy bar. Okay, those are normal, or Baby Ruth. Those are normal ways that a bowel movement should look. They should kind of look like a log. They should be soft. They should be brown. Okay, a few lumps here and there is not the end of the world. There's a good picture of what normal stool looks like on page 321 of your book. Okay, the formed with lumps is okay. Formed with cracks, they might be a little dehydrated. They might not, that might be the sign of constipation. Smooth and soft is always best. Small hard lumps is not a good idea. Small soft lumps is not a good idea. Loose and unformed or watery means diarrhea or infection or bacteria. So those are not good. So the best one is the smooth and soft. It kind of looks like a brown banana. That is the best type of stool to have. Okay, there's also a picture of the different colors that stool can be. They can be from white all the way down to black. You want to be in that normal brown range. The brown is where we want to be. Okay. So they're on page 321 of your book. If you see a stool or a bowel movement come out of a patient and seems strange to you, maybe it's funny colored, maybe it smells different, maybe it's shaped weird, maybe you see something floating or moving in it, save the bowel movement and get the nurse to look at it for you. Okay, so not only do we look at color, we look at the amounts. And that can get a little tricky because what you think may be a huge poop or a huge bowel movement may not be that big. Okay, so my idea of small and my idea of large may be different than your idea of a large or small. So when you're talking about the amounts, it's always a good idea to say, because stool is formed, you can't really measure it in a cylinder or in a hat. So it's always a good idea to say, oh, he had a bowel movement. It was brown and it was about the size of, say, a normal size Snickers bar, or it might be the snack size Snicker bar. Okay, so you have to be able to, or you might say it was like a miniature Snickers. Well, that's not good. Miniature size Snickers is good, but if you say it was a normal Snicker size, that's a good idea. Now you guys don't want to ever have Snickers bars again. Okay, you might have to describe it as, oh, it was only like 2 inches, or it was 6 inches. So you want to make sure you're able to explain to the nurse how big it was, even if you have to hold your hands out and say it was this big or this big. Okay, so consistency is important too. You need to let the nurse know if it seems like there's a constant pattern going on here, like every time the patient eats, they're in the bathroom cramping and having diarrhea. Well, then something's going on with their digestive system. So consistency is important. You also need to make sure the person's going on a regular basis. So consistency could be how often are they going? It could also be, are they going on a regular basis? Meaning, have they had a bowel movement today? If they haven't had one today, do they have one tomorrow? And if they don't have one tomorrow, you probably should let the nurse know, because if they're not having bowel movements within 48 to 72 hours, 2 or 3 days, that's a problem. Okay. You also want to be looking for blood or mucus. The odor is important. Poop will smell. Okay. Bowel movements will smell. And depending on if they have a bacterial infection or some kind of stool infection going on, they smell different. Okay. They might smell like a spoiled egg. When you become a nurse, if you guys go for nursing, you will start to, especially work in a hospital setting, your nose kind of becomes like a hound dog, and you can start detecting different bacteria. So you might smell a stool and be like, oh, that bowel movement or that patient's, that room smells like it's C. diff, or that smells like it's rotavirus. Those are all different viruses or infections that we can get in the stool and the GI system. So odor is important, okay? Describe what the odor was. Oh, it was foul. It smelled like rotten eggs. It smelled like dried up blood. Try to explain the odor. If you can't do that because it's grossing you out, save the stool for the nurse to do it, okay? We're used to looking at poop and detecting it. Shape and size is important, okay? And then any complaints, pain or discomfort that the patient is having, you want to know too, okay? These are things you're looking for. Our goal is to have our patient be regular, meaning they are having bowel movements at least once a day or once every 2 days. They're not going more than 3 days without a bowel movement. So how can we help them along to do that? Well, we can increase their fluids, because the more fluid they have, the softer their bowel will be and the easier it will be for them to pass their bowel movements. We can increase the fiber in their diet, so we can make sure that they're eating plenty of fruits and vegetables because they help. Okay. You could also provide for privacy. It's very difficult for somebody to have to use the bathroom or use a bedpan with somebody standing there. So if you have to put somebody on a bedpan so they can defecate or have a bowel movement, pull the curtain, allow for privacy. If you have to put them in the bathroom and they're going to sit on a toilet, make sure to have a call light. Make sure they're safe to leave on the toilet, then close the door and just stay close by. It's very difficult and uncomfortable for a person to have somebody staring at them when they're trying to have a bowel movement. Habits are really important. Ask the person, ask the family, what is the normal habit? How often does a person usually go to the bathroom and have a bowel movement? Is there a schedule? It seems like they do it more at nighttime or they do it more in the morning. Like my husband has a bowel movement every day when he comes home from work because he doesn't like to use the bathroom at work. So he's more comfortable and it's easy for him to pass his bowels at home. So he uses our bathroom at home. And a lot of people are like that. A lot of people don't like to use public restrooms to go and have a bowel movement. And then there's the diet, high fiber foods. Make sure you understand high fiber foods like fruits and vegetables. They have this residue that they leave inside us, and it makes our stool bulk up, and it kind of coats the feces. So the feces moves through the body, moves through the intestine, and becomes a bowel movement. Okay, so fruits and vegetables, whole grains, things that are high in fiber, leave a residue that helps move the bowel movement and prevents constipation. Make sure you know that. Know what kind of foods leave a residue. Fruits and vegetables and whole grains. Other things that you need to understand is some things in the diet may cause gas or bloating, and we don't want that to happen. Okay, so when a person has gas or bloating, or they have flatus, or they're farting a lot, it's usually because something in their diet could be affecting their intestinal system. It's slowing down the peristalsis, okay, or it's aggravating the peristalsis. Peristalsis means the movements, so it's slowing things down or aggravating the movement. Common things that do that are cauliflower, broccoli, beans, onions, cucumbers, cabbage. They all can make people gassy and promote bloating. Okay, so if you notice a person's having a lot of bloating and complaining of gas, we might want to look at their diet and see what are they eating and maybe decrease some of these things in their diet. If they're having a hard time going, we're going to increase the fruits and vegetables and whole grains. All right. Other things that you need to consider. Your patient should have 6 to 8 glasses of water a day. So should you. The more water you take in, the softer it is for your body. The easier it is for your body to pass the bowel movements, and the softer your stool will be. So keep yourself hydrated. It seems like warm liquids, like hot tea, hot prune juice, even coffee, will stimulate the movement. So again, peristalsis, this word peristalsis is the movements of the fecal matter for the intestines. So we want the poop to get moving. So sometimes we'll offer warm liquids because they seem to stimulate the movement more than cold liquids. Okay, so like hot tea, coffee, prune juice warmed up is a really good one. Activity is huge too. If somebody is not active, their bowel will be sluggish and they will not be passing bowel movements. They'll be slower to pass them. So it's very important that people that remain active. If it's an elderly person who doesn't move much, their risk of getting constipated and not being able to pass their bowel is higher. Okay. If they're bedridden, meaning they can't get out of bed and they can't get up and walk, because walking helps increase the movement, and exercise does too. If they can't get up to exercise or to walk, you can lay them while they're laying in the bed, encourage them to bend their knees or bend their legs up and down and move their legs. Okay. I don't know if you ever had anybody ever dealt with a gassy baby or a baby that might be constipated or fussy because they need the farts. You do that with a baby. You usually sit them down, you lay them down in the bed, and they're on their back, and you pump the legs like bicycle legs up, or you pump their legs like they're little bicycle pedals, and you move them up and down and up and down. And as you do that, like you're dancing with them, you make them dance. They will let out a fart, and they'll kind of giggle, and they'll stop being crabby. So we can't do that with our adult patients. We can't be like, okay, let's lay you down on the bed and let's move your legs and dance like you're a little baby doll. But you can encourage them to move side to side in the bed. You can encourage them to bend their legs up and bend their legs down if they're having a hard time, because if they can't walk, they got to try to release it somehow. That could be a way to do it if they're in bed. Some drugs cause constipation or diarrhea. There's all different kinds of drugs. There are drugs that will constipate a person, like iron pills, and different vitamins. There are also drugs like antibiotics who can make people have diarrhea. It's a side effect of the medicine. So drugs can affect how a person's bowel movements are happening. If they have a disability, they're not able to control their bowel. They might be incontinence. As we age, our bowels will change too, and our risk of constipation, meaning the bowel movement being slower or bowel being stuck inside us, is higher. So as we age, our risk for constipation is higher. Also, people might lose the control of the bowel and have accidents, or they might become completely incontinent. And I will tell you this, I do not like working with old people. That's not my specialty. I'm more trauma and surgery and younger and blood and guts. But old people are very, very fixated on if they're going to have a bowel movement or not, and when their last bowel movement was. Usually if you ask somebody, when was your last bowel movement, and you guys are 20 years old or 17 years old, you might think about it for a minute. But old people can tell you, I have not pooped in 3 days. What can you do to help me poop? They'll ask the nurse, can I get a stool softener? Can I get some prune juice? I haven't pooped. It's like they are just focused on their poop. They do not want to be constipated. Okay. So that was all covered, like the diets and the drinking of the water, and exercise and activity is all on page 322 of your book. Make sure you know on page 322 of your book, box 22.1, the blue box about safety and comfort for bowel needs, what you should do to help your person and how you can provide safety for them. Okay. And that's right here. Assist with bowel needs promptly. If they put the call out on and they need to get to the bathroom, they need to have bowel movement, you need to help them. You need to do it in a timely manner. Ask visitors to leave the room. Close the door for privacy. Pull the curtains. Close the windows so nobody's seen. Place the call light and toilet paper within reach for the person. Leave them if they can be left alone. When they're all done, help them with pericare if they need it. Flush the stool or get rid of the stool unless it's unusual and a nurse needs to see it. Get rid of the stool to avoid odor and bacteria. Assist the person with hand washing. Always make sure that you help them wash their hands after you use the bathroom, whether urine or bowel movement. And make sure you're always following standard and bloodborne pathogens, meaning you're wearing gloves and you are treating them like if not only their fecal matter, their stool gets on you, but maybe that stool might have blood in it. So you're treating it like it's infected with some kind of blood, like hepatitis. Okay, so make sure you follow standard and bloodborne pathogens, which means I'm going to wear gloves and I'm going to wash my hands, especially if I come in contact with the fecal matter because of the fact that I'm at risk. Okay. Next slide is constipation. So constipation is when a person cannot go to the bathroom. Okay. It's the passage of hard, dry stools. So the person's having a really hard time going. They might have cramping. And then when they do go, it's not a soft, smooth movement. It is a hard, they're pushing hard and the stool is hard. And usually it can be cracky looking and dry. So if you look on page 321 of your book, that formed with cracks in its stool is kind of how constipation can sometimes look. Okay. It's not smooth like a banana. It's bumpy and it's hard. Common causes of constipation are things that the patient's not doing. They're not getting enough fiber. They're not getting enough fluid. They're not drinking enough water. Okay. They're inactive. They're not moving. So it's the opposite of what I just told you. Things that help the bowel is high fiber diets, movement and activity, and increasing your fluid. So if the person's constipated, they probably don't have enough fiber in their diet. They might have decreased water intake or fluid intake. They might not be getting enough exercise. They might be taking a drug that causes constipation. A lot of vitamins do, especially iron. It might be that they're elderly and their bowels are slowing down, and there's certain diseases as well. Okay, so constipation can have many different reasons why it happens. There they are in the bullet points on your screen. Constipation is prevented or relieved by diet change, fluid, activity, drugs, and enemas. So we don't want our patients to be constipated. So they do get constipated and they are having a hard time passing stool. We need to do some diet changes. We need to get some fluids. We need to get some... The nurse might have to get some medicines. We have to get some enemas. We have to get the patient up and get him moving. We need to get that bowel moving again. Okay. And we need to help the person along. And once we get it going where it's regular again, we need to keep it that way. So we need to, whatever we did to change, we need to keep that change. So if we had to increase their oral intake and give them more water, we have to make sure we keep doing that so they don't become constipated again. Okay. So again, constipation right here is prevented or relieved. So they have it, you're going to relieve it by doing a diet change, increasing fluids, increasing their activity. Maybe the nurse has to get some drugs or enemas. And then once we have them going on a regular basis, we're going to do the same things to prevent it from happening again. Okay, fecal impaction. So fecal impaction means something is stuck, okay? It's blocked. So fecal impaction is when stool or feces gets stuck and it's not moving down for the person to pass it. Okay, it's a prolonged retention, meaning the feces is stuck inside that retention, means it's not moving. It's sitting there and it builds up and it builds up in the rectum. Okay, so they're not passing it. It's just building up and building up inside them. It usually happens when we don't take care of the constipation. So if somebody's constipated and we don't get that constipation taken care of, we don't relieve it, and we don't keep it relieved, the impaction can happen, the blockage can happen. The person is unable to have bowel movement when they have fecal impaction. Okay. Sometimes what will happen is when they're in the bathroom, they're trying to push and strain, they might just leak or seep. So like they're not going to have a bowel movement, but they might get some liquid stool that's like scoots out of them, or they might like leak stool, but they're not having a normal bowel movement and no big bulk is coming out. Okay. So it's kind of like they leak from the anus, they leak bowel movement, but it's just liquid. There's no pebbles. There's no log, nothing's coming out. And they feel the pressure like they need to go, but they can't get anything out. And all they do is leak. Okay. They have extreme abdominal discomfort, abdominal pain. Their stomach gets distended. Abdominal distension means that their belly gets big and bloated. They can have nausea because they can't get the waste out. So now it's building up inside them that can make them nauseated. They can have cramping because they're trying to push and it won't move down. And they could definitely have rectal pain because there's pressure in the rectum. Okay, so there's your fecal impaction. Again, it happens because constipation is not relieved, and the person will start to leak or seep or have liquid stool around the mass that's stuck inside them. And when you hear mass, do not think automatically cancer. We're talking about just poop being stuck in somebody. Okay, diarrhea. So diarrhea is the complete opposite of constipation. Okay, constipation is when it's hard and it's cracked and you're pushing really hard to get it out. Diarrhea is the frequent passage of liquid stool. So it's just flying out of you. Okay, it's you go to the bathroom, you sit down, and boom, it's shooting out of you like a water hose. What happens is when a person gets diarrhea, the feces has been dropped into the intestines, and the intestine's job is to suck up all the water. But because it's moving through the intestines very quickly, because it's diarrhea, the intestine can't suck up all the water. So when it does get through the intestine and get to the rectum and pass, the water hasn't been sucked up. So now you're passing all the water as well as the fecal matter. And that's what diarrhea is. So the job of your intestine is to take the waste, the feces, and as it moves through the intestine, which is a very long tube in your body, your intestine contracts and sucks all the water out of it. Contracts and sucks all the water out of it. But if it goes through the intestine too quick, like diarrhea does, that water doesn't get sucked up, so it comes out your rectum. The urge to go is urgence. They need to get to the bathroom immediately. They have abdominal cramping. Sometimes they can have nausea and vomiting. Diet and drugs can be ordered to reduce the movements, to slow down the movements. The peristalsis is the movement. So we got to somehow get things to move slower for that intestine. We can't have them shooting through like a roller coaster. So we will maybe change the diets, give them some different fiber or different objects in their diets, some bulk. Okay, they might have to take Metamucil. You might hear that. Or we might also give them a medication to slow down the movements. Okay, and there's different medications. Doctor can order. One of them is called Lumodal, and it helps. Or Imodium is another one that you could take over the counter that helps with diarrhea. Okay, so that's ways that we can order. We want to reduce the movements. So instead of water shooting out of us, the intestine has a chance to suck up the water, and then just the fecal matter is going to be coming out of us. Causes of diarrhea can include infections. Some drugs, especially antibiotics, can cause diarrhea. Irritating foods like spicy foods or foods that are irritating to the stomach. Seeds, things like cucumbers, nuts, those can be irritating and cause diarrhea. And contaminated water or food. We need to talk about C. diff. So we're going to take a minute here. So constipation is on page 323. Make sure you know what a constipated stool is. It's hard and dry. And the person strains to have a bowel movement. Okay. Fecal impaction is when the prolonged retention and buildup of the feces is in the rectum, page 323. Liquid feces passes around the hardened fecal mass in the rectum and is seep from the anus. They have leaking, but they're not having a bowel movement. They're just leaking. Then diarrhea is on page 323. Know that a big risk of diarrhea is dehydration. And then we need to talk about C. diff, which is on page 323 of your book in the green box. C. diff is a very common infection that you can see in nursing homes as well as hospitals. What happens is the person gets the bacteria. It's usually from being on antibiotics. And what happens is, I'm going to read it to you. With C. diff is a microbe that causes diarrhea and intestinal infections. Commonly called C. diff, it can cause death. Persons that are at risk are older, they're ill, and have prolonged use of antibiotics. The signs and symptoms include watery diarrhea, a fever, a loss of appetite, nausea, abdominal pain, or tenderness. The bacteria or the microbe is found in the feces. A person becomes infected with C. diff by touching items or surfaces that have the infected feces on them. Okay. C. diff can be found, so this bacteria can be found in bed linens, bed rails, toilets, bathroom fixtures like the toilet paper holder or the even the bathroom lights. If somebody touches it with the hand that had the bacteria on it. Sinks, care supplies like bedpans and equipment. It could be on walker handles, cart handles, bedside or overbed tables, phones, TV remotes, and any surface. So if somebody has C. diff and they go to wipe themselves and they're not wearing gloves and they get that fecal matter on their hands and then they touch the doorknob and you go in there maybe an hour later to touch the doorknob and open up the bathroom, you now have touched the microbe because it can live on surfaces. So people with C. diff are very contagious. If you're taking care of somebody who has C. diff, you have to make sure that you follow isolation precautions, meaning you're wearing gown and gloves anytime you're going to be going in the room, and you make sure that you are changing your gloves and you hand sanitize on the way out. But hand sanitizer will not kill C. diff. You have to understand that. It is not enough. You have to get to the bathroom or to the sink and use soap and water. So using hand sanitizer when you're coming out of a room with a patient that has C. diff is going to do nothing for you. You have to get to a sink and do proper hand washing with soap and water. Okay, people that have C. diff, your patients usually are in isolation rooms by themselves. They do not share toilets. You don't share bedpans. You make sure if they are incontinent that you're getting rid of their brief and their wipes in the proper disposal bag, and you make sure if they are able to reach down and touch anything that you are giving them proper hand care, because you do not want them touching maybe a brief full of stool and now the stool gets on the bed rail or the stool gets on the call light. Okay. Again, if it's on something, you can easily touch it and it can spread, and then you can get C. diff or the patient's family member can get C. diff. It's very important. Family members also have to, with their visiting, sit in isolation with a gown and gloves on. They cannot be in the room without gown and gloves. Okay, so make sure you read about C. diff, page 323, the green box. Again, no, soap and water is the only way that you're going to clean your hands. You cannot use hand sanitizer. Okay. Oh, fecal incontinence. So just like urine incontinence, people can be fecal incontinent, meaning they have bowel movements and they can't control their bowels, so they just pass it and they're incontinent of feces. So they're having bowel movements in bed. They might be having bowel movements in their clothes. They don't have control of their bowel. They cannot tell you when they need to go. And if they do, they are not able to get to the bathroom in time. Okay. So it's the inability to control the passage of feces or gas through the anus. It can be caused by intestinal diseases like Crohn's disease, colon cancer, rectal cancer. It can be nervous system diseases like maybe somebody has Alzheimer's or dementia, and then they forget their brain doesn't really make the connection of how to use the bathroom any longer to their valves, so they have accidents and they're incontinent. It could be from fecal impaction, meaning something is stuck inside them and they can't go, so all they're doing is leaking out that stool that we talked about. It could be from diarrhea. They have chronic diarrhea and they can't get to the bathroom in time. It could be from maybe they're on an antibiotic and the antibiotic makes their stool very loose and they have to go to the bathroom a lot and they have accidents. Okay. It also could be from aging. Another one is unanswered call lights. They put the call light on, they need to go to the bathroom, and you guys or CNAs or nurse just neglects to answer the call light. And then the person has a bowel movement in their bed, or they try to get up to go to the bathroom on their own and they have bowel movement across the floor, or maybe they didn't make the toilet in time. So unanswered call lights is another reason why people can have fecal incontinence. What we can do for the person, we could try bowel training. I'll talk to you about that in a minute. We can help them with elimination after meals and every 2 to 3 hours. We can give them incontinence products like the proper brief to wear and make sure they are kept clean with their clothes and their linens, and give them good skincare. So if somebody is fecally incontinent, okay, we have to make sure we're keeping them clean, and we have to make sure that they have clean linen and their skin is taken care of. So they cannot sit and poop or sit in bowel movement. It will eat away at the skin. So you have to check those people that are incontinent much more often than an incontinent person and make sure you're keeping them clean. You might be able to put them on a bowel training or start getting them to eliminate their bowels by putting them on schedule. Okay. So the schedule it will be on your care plan for your patient, but it might say toilet patient before meals and after each meal. Or it might say toilet the patient every 2 hours for a bowel movement. So it depends on the person's habits. It depends on what the doctor orders. And then once they're on a bowel training program, you need to read what's on the care plan and follow it along. It might be patient needs to be toileted after every meal, and patient needs to sit on the toilet for 10 to 15 minutes in an attempt to have a bowel movement. Okay, read your care plans and know that's the bowel training. You have to follow it. They're trying to get this guy to be continent and not have fecal incontinence any longer. Flatulence. Oh my goodness. I think this is the last slide I have to do, you guys. Flatulence. Yeah. Flatulence is on page 324. Okay, it just means gas. So if somebody has flatulence, they have a gas buildup. Okay, they're bloated. When they pass it, it's called a flatus. So, we say fart, but when somebody farts or passes gas, they had a flatus. So the doctor, especially after having abdominal surgery, the doctor might ask the nurse, how's the patient doing? We're like, oh, he's having a couple ice chips here and there, no nausea. And he'll say, has he passed flatus yet? And if you don't know what flatus is, you'll be like, what are you talking about? And sometimes I've even seen surgeons go in the room and ask the patient, how are you doing? Oh, I'm good. I'm really hungry. Okay. And they ask the patient, have you passed any flatus yet? And the patient's like, and usually I'm in the corner of the room, I'm like, he wants to know if you've passed any gas yet. Have you farted or belched? Okay, so flatulence is the passing of the gas. Okay, it's also called flatus. So gas or air passes through the anus. Once we let it go. Like, I know, don't laugh, Miss Bartels, like Olaf. Okay, so once the person lets it ride or lets it go, it's no longer flatulence, it's flatus. So when it's inside us, it's flatulence. When they let it go, it's flatus. Flatulence is the excessive formation of gas or air in the stomach and the intestines. So when it's inside us, it's that bloating feeling. Once we let it go, the intestines are no longer bloated, okay? And the person then passes gas. It could be belching or farting. The following help produce flatus. Getting a person up and walking them. Getting them to exercise. So when we get a person up and we start with, they're really bloated after surgery. Miss Chrissy and I do this all the time when we worked in surgery. If a person was, I need more pain medicine, my stomach hurts so bad, we would be like, no more pain medicine, because pain medicine slows down the process of the bowel and the gas moving. So be like, you know what? We need to get you up. And they're like, are you kidding me? I'm in so much pain right now. And we say, no, we need to get you up, either sitting in the chair or go for a short walk, because that's gas that's building up in you. We got to get the gas to move out. Pain pills will not help with it. We need to get them moving. So exercise, walking, moving them in the bed, like side to side, laying them on the left side. If you remember when we did bed positions, the left side with their leg bent up is that position that gives relief to the rectum. It's called SIMS. Left side lying is really good when somebody is bloated or when we're trying to get them to pass a bowel movement. So on their left side with their leg bent up, SIMS position, if you remember from chapters 14. And then sometimes to help the person move the bowel or move the gas, the doctor might order an enema or some drugs like a suppository to relieve the flatulence. And we will talk about those tomorrow in lecture. We are done.